Welcome to our video on pituitary adenoma and hyperprolactinemia. Let's get started. Here is our overview slide. Let's begin with pituitary adenoma. With regards to this topic, we'll be discussing the definition and classification, clinical features, diagnosis, and management. Pituitary adenoma is a benign tumor of the pituitary gland. It can be classified by cell of origin. This means it can be a lactotroph, somatotroph, gonadotroph, thyrotroph, or corticotroph adenoma. It can also be classified by size. A microadenoma is smaller than 1 centimeter, and a macroadenoma is larger than 1 centimeter. In addition, pituitary adenoma is commonly divided into functioning adenoma, which secretes hormones, and non-functioning adenoma, which is hormonally silent. Let's discuss functional pituitary adenoma. As you would expect, the presentation and symptoms of a patient with functional adenoma largely depend on the type of hormone produced. It can be prolactin secreting, also named prolactinoma. It can be GH secreting, which causes gigantism in children and acromegaly in adults. Also, a functional adenoma can be ACTH secreting, which causes Cushing disease. The pituitary gland can also produce TSH, FSH, and LH. So it would stand to reason that pituitary adenomas could also be TSH, FSH, or LH secreting. However, these types of functional adenomas are rare. Also, functional adenoma can less commonly lead to mass effect symptoms when it gets large enough to compress local tissues. These symptoms include headaches as well as visual field defects when compressing the optic chiasm. Let's move on to non-functional adenoma. The most common type is gonadotroph adenoma, referring to an adenoma that originates from cells that secrete FSH and LH. We know from step 1 that FSH and LH are composed of 2 subunits, common alpha subunit and different beta subunit. However, gonadotroph adenoma usually secretes only the common alpha subunit, which is biologically inactive. So that's why this adenoma is non-functional. A patient with non-functional adenoma can present with mass effect symptoms such as headaches and visual disturbances. The adenoma can also compress the normal cells of the pituitary, causing symptoms of hypopituitarism. Mild to moderate elevation of prolactin levels may also occur. And we'll discuss this in more detail as we progress through the lecture. Here's an illustration that shows the location of the pituitary gland in the sella turcica. Note also the optic chiasm right here. When the pituitary adenoma gets large enough, it can compress the optic chiasm and lead to visual field defects. And do you recall what is the most likely visual field defect? Well, remember from step 1 that it typically leads to bitemporal hemianopia. So be aware of this because it's a high-yield presentation typically found in vignettes. Okay, let's move on to the diagnosis of pituitary adenoma in general. An MRI of the pituitary is an essential step. Visual field testing should also be done to evaluate the presence of bitemporal hemianopia. Testing for hormone hypersecretion should also be considered. For example, we measure serum prolactin when we suspect a prolactinoma, serum IGF-1 when we suspect acromegaly, as well as serum ACTH and 24-hour urine-free cortisol if we suspect Cushing disease. Testing for hypopituitarism should also be considered. For example, we can order a serum cortisol at 8 a.m., thyroxine, FSH, LH, and estradiol in women, as well as testosterone in men, to evaluate for hyposecretion of these hormones. So all you need to know right now is that when you suspect a pituitary adenoma, get an MRI, do visual field testing, and be ready to check relevant hormone levels. Okay, moving on to management, functional pituitary adenoma. Transsphenoidal surgery is first-line treatment for most cases of functional pituitary adenoma. However, medical therapy can be considered when surgery is not achievable or effective. Also, you should be aware that medical therapy is the first-line treatment for lactotroph adenoma or prolactinoma. Radiation therapy can also be considered when surgery and medical therapy are not effective. Finally, please note that there is a risk of hypopituitarism when performing transsphenoidal surgery or providing radiation therapy. Let's take a look at this image, which shows a lateral view of the sphenoid sinus and the pituitary gland, which sits in the sella turcica. This image helps us imagine how surgical instruments can go through the nasal cavity and sphenoid sinus to reach the pituitary adenoma when performing transsphenoidal surgery. Transsphenoidal surgery is the initial step of management in most cases of non-functional pituitary adenoma, particularly when neurologic symptoms are present. Yearly monitoring of the adenoma size and pituitary function can be considered if the adenoma is asymptomatic and there is no threat to visual function. Finally, radiation therapy can be considered if the adenoma recurs or regrows progressively after the surgery. Okay, let's move on to the next topic, hyperprolactinemia. With regards to this topic, we'll be discussing the etiology, clinical features, diagnosis, and management. Let's begin with the etiology. Hyperprolactinemia can be due to physiologic, drug-induced, or pathologic causes. Pregnancy is the most important physiologic cause. It should always be excluded first in a woman with hyperprolactinemia. Medications that can cause this include SSRIs, antipsychotics such as risperidone, and metoclopramide. Pathologic causes include prolactinoma, non-functional pituitary adenoma, primary hypothyroidism, and chronic renal failure. In our lecture, we'll concentrate mostly on prolactinoma as a cause of hyperprolactinemia. A premenopausal woman with hyperprolactinemia mainly presents with oligomenorrhea or amenorrhea. Galactorrhea can also be present in some cases. However, in postmenopausal women, compressive symptoms of a pituitary adenoma are more prominent. These include headaches and visual disturbances. Men with hyperprolactinemia present with a low libido, erectile dysfunction, and infertility. Atrophic testes can be found on physical examination, and compressive symptoms of the adenoma can also be found. Alright, let's discuss some of the pathophysiology using this illustration. We know that dopamine from the hypothalamus inhibits prolactin secretion from the anterior pituitary. On the other hand, TRH, that is also secreted from the hypothalamus, can stimulate prolactin secretion. Increased levels of prolactin inhibit GnRH, and this leads to decreased production of the gonadotropins FSH and LH, which in turn leads to hypogonadotropic hypogonadism and decreased estrogen or testosterone levels. This is why men with hyperprolactinemia present with a low libido and infertility, and also why postmenopausal women with hyperprolactinemia present with oligomenorrhea or amenorrhea, vaginal dryness, and infertility. Alright, let's try a question. Based on what we learned in the previous slide, can you interpret why non-functional pituitary adenoma, primary hypothyroidism, and chronic renal failure lead to hyperprolactinemia? First, non-functional pituitary adenomas can compress and disrupt the dopaminergic inhibitory pathway. This in turn leads to hyperprolactinemia. Primary hypothyroidism causes TSH and TRH elevation. So elevated TRH leads to stimulation of prolactin secretion and thus hyperprolactinemia. Finally, chronic renal failure causes decreased clearance of prolactin, which also leads to hyperprolactinemia. Let's try another quick question. Why is a prolactinoma in postmenopausal women commonly diagnosed late in comparison to premenopausal women? Well, postmenopausal women have low levels of estrogen because they've already gone through menopause. So early symptoms of a prolactinoma are often minimal and nonspecific. Therefore, a prolactinoma is not discovered until it gets large enough to cause mass effect symptoms, such as headache and visual field defects. That is opposite to premenopausal women who present early with menstrual cycle dysfunction and less commonly galactorrhea. Alright, here is an algorithm we've created for hyperprolactinemia. When hyperprolactinemia is suspected based on presentation, the first step is measuring the levels of serum prolactin. If these are normal, we should then consider other causes of symptoms. When the prolactin level is elevated, we move on to the next step. However, sometimes prolactin levels are slightly elevated due to a physiologic increase during sleep, intense exercise, or emotional stress. This is why the measurement should be repeated if prolactin levels are slightly above the normal upper limit. So once hyperprolactinemia is confirmed biochemically, causes like pregnancy, hypothyroidism, renal failure, and medications should be excluded before thinking of pituitary adenoma. Therefore, a pregnancy test, serum TSH, and serum creatinine levels are usually ordered. The patient should also be asked about his or her medications. If these causes are excluded, we move on to perform an MRI of the hypothalamic pituitary region. And here, a pituitary mass can be found. It can be a prolactinoma or a non-functional pituitary adenoma. However, a prolactinoma is more likely when the serum prolactin levels are above 200 nanograms per liter on one measurement or above 100 nanograms per liter on 2 repeated measurements. If no abnormal findings are detected on an MRI, then the patient is diagnosed with idiopathic hyperprolactinemia. Alright, now let's focus on the management using the same algorithm. So if we get a pituitary MRI and this is normal, we diagnose idiopathic hyperprolactinemia, and this is treated with cabergoline. On the other hand, if the pituitary MRI shows a mass and the prolactin levels are low, we've diagnosed a non-functional pituitary adenoma. If the patient is asymptomatic, we monitor them, And if they're symptomatic, we perform transsphenoidal surgery. On the other hand, if the prolactin levels are high, we've diagnosed a prolactinoma. And this is treated with cabergoline. And if this medication is not effective, we then move on to treat with transsphenoidal surgery and potentially radiation therapy. All right, let's finish up with a final question. A 34-year-old woman presents to the office with a complaint of amenorrhea for 4 months. She states that she has gained more weight recently. She is married and has 2 children. Menarche occurred when she was 13 years old, and her menses have been regular with 5 to 6 days of bleeding. She takes no medications, and her medical history is unremarkable. Her temperature is 37.3 degrees Celsius, blood pressure is 105/70 millimeters of mercury, and heart rate is 70 beats per minute. On physical examination, the skin is dry, the hair is coarse, and there is delayed relaxation of deep tendon reflexes. A pregnancy test is negative. The patient is diagnosed with Hashimoto thyroiditis. What are the laboratory findings most consistent with this diagnosis? A. Prolactin 200, decreased FSH, normal TSH. B. Prolactin 85, decreased FSH, decreased TSH. C. Prolactin 75, normal FSH, normal TSH. Or D. Prolactin 90, decreased FSH, increased TSH. All right, we have a middle-aged woman who complains of amenorrhea. She's gained more weight recently, and on physical examination, there is dry skin, coarse hair, and delayed relaxation of deep tendon reflexes. She's diagnosed with Hashimoto thyroiditis. So the question clearly states that we have a condition of primary hypothyroidism. Let's remember that in primary hypothyroidism, there is decreased or absent production of thyroid hormones. This in turn stimulates the overproduction of TSH from the anterior pituitary and TRH from the hypothalamus. We already learned in our lecture that elevated TRH stimulates the secretion of prolactin and leads to signs and symptoms of hyperprolactinemia. Also remember that elevated levels of prolactin inhibit GnRH, which leads to decreased FSH and LH. So with this in mind, the correct answer is D. Prolactin 90, low FSH, elevated TSH. Let's discuss why the other options are incorrect. In choice A, we have a prolactin level of 220, low FSH, and normal TSH. These findings are most consistent with a prolactinoma. A prolactin-secreting pituitary adenoma, or prolactinoma, is typically associated with serum levels of prolactin above 200 or above 100 on 2 repeated measurements. Elevated prolactin levels lead to decreased FSH, and TSH is usually normal unless the adenoma is large enough to compress the thyrotroph cells of the anterior pituitary. So choice A is incorrect. In choice B, we have a prolactin of 85 along with low FSH and low TSH. These findings are most consistent with a non-functional pituitary adenoma. This causes low to moderately elevated levels of prolactin due to disrupting dopaminergic inhibitory pathways. Elevated prolactin leads to decreased FSH, and TSH is low, likely due to compression of normal thyrotroph cells by the adenoma. So choice B is incorrect. In choice C, the prolactin is 75 with normal FSH and normal TSH. It can be due to drug-induced hyperprolactinemia. Prolactin in this condition is often elevated only slightly or moderately. FSH can be normal or low, and TSH is normal. So choice C is incorrect. So again, the correct answer is D. And that concludes this section.